Good evening, sir. I herewith thank the opportunity for the presenting the opportunity. So my topic is on hypertension in pregnancy. So coming to the topic, so hypertensive disorders of pregnancy, it's a second leading cause of maternal mortality after postpartum hemorrhage, and it includes both short and long-term maternal and fetal morbidity produces, and the incidence is roughly around 10%, and the incidence of eclampsia is around 5%. So hypertensive disorders of pregnancy are broadly classified as chronic hypertension, gestational hypertension, preeclampsia or eclampsia, and preeclampsia superimposed on chronic hypertension. So the pre-pregnancy before 20 weeks, the chronic hypertension is detected before 20 weeks of gestation. It is known as chronic hypertension. And if it is without any secondary cause, it is called as essential hypertension. And if the patient is identifiable causes known, it is called as secondary hypertension. And it is called white coat hypertension if the systolic blood pressure is more than 140 and diastolic more than 90 when measured in clinic, and less than 135/85 in the house BP or ambulatory BP monitoring. And masked hypertension when the BP is less than 140/90 when measured in clinic and BP more than 135/85 at other times. And more than 20 weeks, if the BP is present, it is called gestational or transient gestational hypertension. It is the hypertension arises de novo more than 20 weeks of gestation in the absence of proteinuria or the symptoms of preeclampsia. And the transient gestational hypertension, it is hypertension arising more than 20 weeks in the clinic, which resolves with repeated BP readings even without treatment. So the classification includes preeclampsia. It is a gestational hypertension after associated with more than 20 weeks of gestation. It includes any of the four. It may be proteinuria or maternal end organ damage introducing neurological complications like altered mental status, blindness, stroke, clonus, seizures, or pulmonary edema, or hematological complications with low platelet count, DIC or hemolysis, or acute kidney injury, or elevated liver transaminases. Number 3, uteroplacental dysfunction. So if the PH classification, the pregnancy more than 20 weeks, if it is superimposed on chronic hypertension, among women with hypertension, development of new proteinuria with maternal organ damage or evidence of uteroplacental dysfunction as described above. So any patient with chronic hypertension, if he develops new proteinuria or evidence of other maternal organ dysfunction or evidence of uteroplacental dysfunction, it is pregnancy chronic hypertension superimposed with the preeclampsia. So roughly, if the BP is more than 140/90, less than 20 weeks and more than 20 weeks, less than 20 weeks, it is chronic pre-pregnancy, chronic hypertension, and at risk, the patient is at risk of preeclampsia. So if more than 20 weeks of gestation, if the presence of target organ involvement along with the symptoms or lab anomalies, if there is no target organ involvement, then she is labeled as gestational hypertension. If there is target organ involvement, there is classified as preeclampsia, which includes non-severe preeclampsia, severe associated or HELP syndrome. So coming to the investigations and management, so if the BP is more than 160/110 millimeter mercury, the patient's investigations and monitoring is graded. Women should be evaluated and treated with antihypertensive therapy in hospital, and continuous fetal heart rate monitoring is advisable until the BP is stable. If it is transient, more frequent BP measurement is warranted because of an elevated risk of preeclampsia or sustained hypertension. If it is white coat hypertension, still more frequent BP monitoring is warranted because it is an elevated risk of preeclampsia. And if it is masked hypertension, and also follow-up is needed. For proteinuria patients, so the screening for preeclampsia in low risk normotensive women is routinely done, and more definitive testing for proteinuria includes protein creatinine ratio or albumin creatinine ratio or 24 hours protein sample should be performed when preeclampsia is suspected. So if the patient is at chronic hypertension, consider investigating for target organ damage, and secondary hypertension causes should be ruled out. And frequency should be followed up by the level of BP and the individual risk outcomes. So for gestational hypertension, so we have to include both maternal and fetal surveillance. So we have to first rule out preeclampsia, number 2 is rule out proteinuria, and if preeclampsia is suspected, then we have to reevaluate. And also the warning signs, we should inform the patient regarding the occurrence of nausea, headache, vomiting, and any systolic BP dipstick, proteinuria or pulse oximetry. Then the fetal markers, we have to do the fetal ultrasound and umbilical artery Doppler and the recent angiogenic markers should be done. If any fetal growth is restricted, and fetal surveillance guidance should be followed up. So coming preeclampsia, here we are doing the also along with proteinuria, we are risk stratifying the patient. So maternal risk factors other include platelet count, oxygen saturation, serum creatinine, and the AST-ALT ratio should be done. For follow-up, we have to twice weekly the measurement of gestational age, chest pain, dyspnea, oxygen saturation, platelet count, serum creatinine, and AST-ALT level should be done. And fetal growth restriction should be monitored every 2 weeks. So we have to follow the secondary cause of hypertension. It includes the obstructive sleep apnea, renal vascular disease, and renal parenchymal disease, and primary hyperaldosteronism, and hyper and hypothyroidism, and pheochromocytoma, and Cushing's disease, and coarctation of aorta, and drug-induced hypertension like antidepressants, steroids, sympathomimetics, or herbal drug abuse. So coming to proteinuria, so when do you say proteinuria? Proteinuria should be defined as more than 30 milligram per millimole of urinary protein creatinine ratio in a spot urine sample, or albumin creatinine ratio of more than 8 milligram per millimoles, or more than 0.3 grams per day in a complete 24 hours urine collection, that is more than 300 milligram per day in a 24 hours urine collection, or in a spot dipstick if it is more than 2+. So we have to have both systolic blood pressure and diastolic by 2 methods using standardized technique. In women in a sitting posture, in the feet flat on the floor, the cuff size should be appropriate, and the Korotko sound should be correctly done for phase 5 for the diastolic BP measurement, and the arm level that should be at the chair, and both sides arm should be measured. Any BP difference between the both upper limb should be notified. And hypertension should be defined more than 140/90 based on average of at least 2 measurements. And BP should be repeated to confirm true hypertension. If hypertension is severe, then repeat BP should be done within 50 minutes, or otherwise repeat in at least 4 hours or at least 2 outpatient visits. So these are all the normal physiological changes in pregnancy. So normally the systolic blood pressure falls by 4 to 6 millimeter. The lowest values at 20 to 24 weeks. Then rise gradually to the pre-pregnancy values at term. The mean arterial pressure falls by 6 to 10, and the heart rate usually increases by 12 to 18. By early second trimester becomes stable, and the stroke volume and the cardiac output increases approximately by 30%. So these are all the investigations: hemoglobin and hematocrit, platelet counts, serum AST, ALT, and the LDH levels. So the proteinuria estimation, along with the proteinuria, we have to measure serum uric acid level and the serum creatinine level. So coming to the investigations, the determination of the soluble FMS like tyrosine kinase to placental growth factor. The ratio is one of the investigations to preclude the patients, that is, who are all the patients who are more prone for preeclampsia. So if the patient has got any high risk factors, we can subject them for a soluble FMS like these are angiogenic markers. FMS is like tyrosine kinase and placental growth factors. So someone they can give the ratio. If the ratio is less than 38, they can possibly rule out the development of preeclampsia in the next 2 weeks. If the ratio is more than 85, the patients are most likely to have or will develop preeclampsia in the next 4 weeks, and they require intensive monitoring. And the Doppler ultrasound of the uterine arteries after 20 weeks of gestation is useful in detecting women high risk of gestational hypertension, preeclampsia, and intrauterine growth retardations. And also performing an ultrasound of adrenals, urine metanephrines, and in all pregnant women hypertension recommended as a screening for pheochromocytoma. So the soluble FMS like tyrosine kinase to placental growth factor ratio to rule out impending preeclampsia or severe preeclampsia in the pre-existing in the next 2 weeks. If the ratio is more than 85, we can predict the risk. So this is a risk scoring system. So the full Pairs model, which includes the patient's gestational age, presence of chest pain or dyspnea, the pulse oximeter saturation, development of platelet count, serum creatinine values, and the AST, ALT levels. It should be monitored. If the BP is still high, this is a preeclampsia integrated estimate of risk score model. for adverse maternal and fetal outcome in hypertensive disorders of pregnancy. So the pregnancy history, these are all the high risk factors for patients and low risk factors we are classifying. If the patient is having a previous history of preeclampsia, the score is 1, and if the patient is having a pre-pregnancy BMI of more than 30, the score is 1. If the patient is having a chronic hypertension, pre-gestational diabetes, chronic kidney disease, SLE, antiphospholipid antibody syndrome, and if the patient has undergone assisted reproductive therapy, these patients are aligned 1 factors. And if there are 2 more risk factors, there are moderate risk factors are prior history of placental abrasion, prior stillbirth, prior fetal growth retardation, or maternal age of more than 40 years, nulliparity and multifetal pregnancy, they are assigned score of 2. So the prevention, so low dose aspirin should be advised for this patients with high risk factors from before even started from the 16 weeks till 36 weeks. So the aspirin should be 80 to 162 milligrams per day should be started. Along with the aspirin, the patient should be given calcium supplementation, maximum up to 1.5 to 2 grams. So if we are unable to measure the quantification of calcium intake, we can roughly advise 900 milligrams of calcium supplementation is not beneficial, and the exercise therapy is advisable, and dietary advice and strict glycemic index and exercise should be advised for prevention of the preeclampsia. Coming to antihypertensive therapy, hypertension and pregnancy should be treated with drugs. So the urgent treatment should be done if the BP is more than 160/110. The target BP should be diastolic BP of less than 85 millimeter mercury regardless of the systolic blood pressure. And non-severe hypertension should be treated with first-line agents like oral methyldopa or lebetalol or nifedipine. Severe hypertension should be treated with first-line drugs like oral nifedipine, oral lebetalol. So coming to the algorithms, so tight control should be diastolic BP should be less than 85, that is our target. If the diastolic BP is less than 85, we can reduce the existing hypertensive medications. If it is more than 85 diastolic, we have to increase the dose of existing antihypertensive drugs. If the systolic BP is more than 160, increase the dose of existing medications or start new antihypertensive drugs regardless of the diastolic blood pressure. So coming to the dosage of individual lebetalol, the initial starting dose is, the maximum tolerable dose we can give is 200 milligrams. For nifedipine 10 milligram, maximum 120 milligram per day. Either if it is short acting, it is long acting, it is up to 120 milligrams per day. And methyldopa, the only side effect is mental depression, maximum dose up to 2250 milligrams per day. This is regarding the IV usage of lebetalol, up to 10 milligrams, maximum up to 140 to 80 milligrams. Hydralazine, the maximum dose is 20 milligrams. So the IV lebetalol infusion, the initial dose is, the onset of action occurs within 5 to 10 minutes. The 10 to 20 milligram bolus initial dose, the maximum tolerable dose is 300 milligram. The main side effects are the fetal bradycardia and the antagonist hypoglycemia. And hydralazine, just a 5 milligram initial dose, maximum only 20 milligrams. So when severe hypertension is resolved, we have to switch over to routine oral medications. If the nifedipine or hydralazine were the initial drugs, choose oral lebetalol or methyldopa, and do not exceed maximum dose of IV lebetalol, do not exceed maximum dose of IV hydralazine 220 milligrams. So other drugs that can be used, nitroglycerin and esmolol. Coming to women with eclampsia, should receive magnesium sulfate therapy to prevent further worsening of it. The dose of magnesium sulfate is just 4 grams of magnesium sulfate, then 5 grams of magnesium sulfate in each buttocks IM, which is a prophylactic dose or maintenance dose of 1 grams per hour continuous infusion for 24 hours. So in time we have to monitor the reflexes, blood pressure, heart rate, respiratory rate, pulse oximeter, saturation, and along with every hour urine output and deep tendon reflexes we have to monitor for signs of toxicity. So these are all the drugs, it should not be used. The AC inhibitors should not be used with caution. Then diuretics recommended if they prescribed before gestation or patients appears to be salt sensitive, but not at all recommended in preeclampsia. Then direct vasodilators and beta blockers should be little bit because of the perinatal adverse effects in the early pregnancy should not be used. So coming to the postpartum care, so all the drugs should be continued even after the postpartum period also, because sometimes even the preeclampsia patients, asymptomatic patients can go for the symptoms immediately after the postpartum period. So the BP should be monitored every 4th hourly, because the BP peaks around 3 to 7 days after delivery because of the redistribution of the fluid. So the antihypertensive therapy should target a similar BP goal as before delivery. And also the 50% of the strokes and 25% of the eclampsias occur after delivery also. So all the drugs should be continued and should be tapered after gradually. So the target diastolic BP is only 85 in the postpartum period also, and counseling should be provided about the risks of gestational hypertension or preeclampsia in the future pregnancies, which is about 4 to 15%. So at 3 months postpartum, all women should be reviewed to ensure that BP, urine analysis and lab abnormalities are normalized, and if proteinuria or hypertension persists, then appropriate referral should be done. So these are all the drugs which are antihypertensives which can be comfortable with breastfeeding. So once delivered, the AC inhibitors, beta blockers, diuretics or hydralazine, methyl dopamine, everything can be given as similar. So conclusion. So hypertensive disorders complicate 10%. If the BP is more than 140/90, preferably on 2 circulatory occasions, the diagnosis is confirmed, and a pre-existing hypertension is associated with 25% risk of superimposed preeclampsia. So the low dose aspirin should be started for these patients from the age of 12 weeks to 36 to 37 weeks of. Is also recommended for high risk of preeclampsia patients and moderate risk of preeclampsia patients as a prevention for eclampsia. And the threshold for the BP should be less than 140/90, and diastolic BP target should be less than 85. So the preferred drugs are labetalol, nifedipine should be considered safe, and enalapril in the postpartum period. Thank you, sir.
A very excellent talk on pregnancy and hypertension. So it's very important to earlier detect the hypertension, and the goal of treating hypertension is predominantly targeted with diastolic blood pressures, and what drugs should not be used in pregnancy is most important. Any physician has to know about it. And initiation of beta blocker early in the pregnancy will have some amount of effect on the fetal growth. So using the safe drug is to go for a calcium channel blocker, and close monitoring. Apart from the drugs, I think there are a lot of other things like yoga, exercises, as well as dietary intake of sodium. So these are the few things which any physician has to impart on the patient once. And now we have assisted reproductive therapy in predominant subset of patients. So hypertension is also on the higher fold compared to the earlier days. So it's been excellently put forward by Dr. Chanda. Now it's open for discussion.